tests. We just changed the answers on the test. So this is kind of what we've done with this. We've changed the format of PCEP, and that basic outline is that we'll have 6 lectures per year on the. So the lecture periods will be the odd months, starting in January, a very odd month. And then the lecture for that month will lead into the skills session the following month. So today, for example, we're going to talk about the science of CPR, what we know about some of the things with advanced life support. I'll give you a little insight on the rock thing. We'll talk about rock again. And next month, we'll practice the session. Now, because we're giving this once a month only, or every other month, and then one lecture per month, we normally tape this on CBTV. And up to now, we have been using GoToMeeting. Go to training, but we've had a problem with that, and we're switching over to another program, but that's not active today. So the tape will only be the CVTV tape, and we'll try to have that available as soon as possible to the training officers. It'll be a requirement before you do the skill session to have seen the tape or attended the live session. Now, we want as much as possible to encourage people to do the live sessions, because that's where you're going to get more information, because we can at least try to shake you to keep you awake, which is harder to do when you're at home watching your own tape. As far as mandatory attendance, I haven't worked that out yet. I know there will be at least one mandatory session, which will be the updates on protocols. But we'll work around that. So this is sort of a work in progress at this point. But I think you'll find out that it'll be a little bit more practical. It'll have a lot more hands-on application for you, and you'll still get credit, just like you always do, for recertification and for the 48-hour refresher and all that stuff. So the only other thing I want to mention right off the top is, remember, it is active flu season. And so if you, AMR has badges or things they can do. We do have the little sticky things that say no flu on it, that way the nurses won't accost you when you go into the emergency department or in through the hospital. They won't accost you for that. No, they'll accost you for other reasons, like why isn't that patient intubated and things like that. Or why is that patient intubated? You know, you can't win. So we have the flu stickers available. John, for AMR, John will have all the flu stickers. They're available for other agencies that transport as well. But if you don't have a badge, you don't have any place to stick the little sticker on, except in your forehead, I guess. We can get a tattoo. This year's flu sticker is a different color, so they identify it as that. So if you didn't get a flu shot, put your mask on when you go in. Now, you know, District 6, District 3 seldom travel in with, or uncommonly travel in with. The nurses are pretty aware that most of you who are going to be transporting, like all of Camas has had their flu shot, I think all of District 3. So, all right. So we'll move on with this. Dr. Macht has the beginning of this presentation. So.
Apologies, I'm a little bit hoarse from yelling at the TV last night. I want to start off with a case review. This is from September 2014. So at 1820, VFD engine 9 and 10, campus medic 42 were dispatched from a cardiac arrest. The report was that the family was performing CPR. At 1823, a VPD officer who had gotten the call as well arrived and took over CPR from the family. At 1826, VFD engine 9 and 10 arrived on scene. This was the initial rhythm, and shock was delivered at 1830. At 1832, the patient had spontaneous respirations. He was gagging on the eye gel. He had AFib at 160 on the monitor. Soon after that, he was talking oriented, had sinus tach, and the medic unit went en route and arrived at P South Southwest at 1857. And so everything that we talk about today is geared around answering this question. How well do we do with this? And so if you take this one example, here's someone who had a condition that has 100% mortality, and he's walking out of the hospital alive. He was probably yelling at the TV last night too. So if you look through the first 8 months of 2014, there were 8 other people like him who had a VFib arrest and are walking out of the hospital alive, doing everything that they want to be doing. And then there were 11 people who did not survive. Either they made it to the hospital with return to spontaneous circulation but were not discharged from the hospital alive, and then some that expired in the field. And so overall, that's about 43% of people who would have died that are now alive with this one specific condition. But I think it's easier to think about it. These are 9 people just in 8 months who are alive because of the work that you've done. The reason I bring this up is that we want to talk about key performance indicators, and I think it's really easy to hear this and to gloss over and to think, oh man, this is another way to make my job harder. But the bottom line is that these are numbers, but these are numbers that represent people and getting people back to the life that they want to be living. So why do we do this? We want to measure our ability to do the right thing. We want to know that what we're doing is working. We have to prove it, both to the citizens who pay for the services, to the patients. We have to be able to prove that we're delivering quality care. And then we have to be able to improve it. To know this is what we've done in the first 8 months of 2014, lets us ask the question, what do we need to do to get better? What would it take so that next year there are 11 people walking out of the hospital alive? So those are the reasons that really motivate me to do this and to talk about this. If that's not enough, there are other reasons, most to do with the changing world of healthcare. So healthcare reform is changing a lot of things. I can tell you that when I go to work, I'm measured on how many patients I see per hour, on how many tests I order. I'm measured on my patient satisfaction, on how well I controlled the patient's pain, how well I communicated with the patient, how well I communicated with the family. And so that increasingly in healthcare, we're called upon to prove that we're delivering quality, whether it's measured by how many patients are alive or how happy the patients are or how well we use the resources that we were given. Because the way that we are getting paid for healthcare is changing. And so what we've had for years in the U.S. is fee-for-service medicine. And still, a lot of what's happening in EMS is based on fee-for-service medicine. A patient gets a charge for a BLS transport or an ALS transport. They get a per-mile charge. But increasingly, systems are doing something more like what Kaiser does, which is they get a fixed amount of money to care for a population. And so rather than a hospital being a source of profit, a hospital becomes a cost center, and the payers for healthcare are trying to keep patients healthy at home. What does that have to do with what we do? It means that if we are not proving that we have a value to the payer in the health system, then that's going to reduce the resources that we have, and it'll ultimately affect what we're given to do our job. So we need to be able to demonstrate value to the people who pay for health care. And that ultimately will probably look like something like pay for performance. And so many areas in healthcare, you're given a bonus based on whether you kept costs down, whether you kept patients alive. And so we have to align our resources with doing the right thing for the patient. Because in the U.S. we spend more than any other country on healthcare, but our outcomes are among the worst in the industrialized world, we have to change, and it's going to affect EMS. And so we can either wait for the change to come to us, or we can say, look, we're going to prove that we provide quality. And I think when you look back at the example, what we do, I don't think there are very many organizations who can point to that many people who are walking, alive, neurologically intact because of what they do. So this all has to do with the idea that Peter Drucker was a management consultant, and so he said what gets measured gets managed. Now, he was also a realist. And I don't know if any of you have ever experienced anything like this, but I certainly have. So I think we have to ask ourselves the question, how do we do this efficiently, and how do we keep the focus on the patient? How do we keep the focus on what is going to improve the patient's life? And so a key performance indicator has to be patient-centered, meaning it has to deal with something that matters to the patient. I would say being alive and not dead matters to the patient. But having pain controlled matters to the patient as well. It has to be something that is meaningful. So we try not to measure things that don't make a significant difference. And then obviously it has to be measurable, and we have to be able to reliably trend it over time. So what are the things that we do in EMS? So our core missions include resuscitating cardiac arrest, relieving respiratory distress, identifying and treating acute coronary syndrome, responding to traumatic injuries, identifying and managing CVA, relieving pain, to identify and treat status epilepticus. So those are some of the examples of what we do in EMS. So when we ask how can we do better at those things, what do we need to measure? We should measure something that is specifically applicable to the patient. So we mentioned not being dead, having decreased pain, other things that manage, say, for acute coronary syndrome. So what's the patient's functional status? Do they have so much CHF that they can only walk 10 feet after their MI, or are they still able to do triathlons? Now, right now, we aren't able to, I can't tell you, of all the patients that we see with respiratory distress, how many get intubated, how many die, because we don't have the link between the hospital and the EMS system. We're working on building that, but there are some cases where we're going to use a substitute where we're going to measure a process rather than the specific outcome for the patient. So chest compression fraction, so the patient doesn't specifically care like exactly how fast and how often you press on their chest, but we have good evidence that the better we do with that, the better we do with keeping patients alive. We have good evidence that if we give people with acute coronary syndrome aspirin, so for every 42 people that you give aspirin, one additional person is going to be alive just because of the aspirin that you gave. We know that CPAP and COPD exacerbation prevents intubation and prevents mortality. So yes, what I ultimately want to get to is to be able to say, look, for all the patients that are treated by this EMS system, this is how, for severe respiratory distress, this is how many live after we treat them. And this is how many ultimately get intubated. But in the interim, I know that this affects that, so I'm willing to look at that. But the ultimate goal is to get to a patient-centered measure so we can say, this is how many patients we keep alive, this is how we treat pain. So Washington State has specific key performance indicators. It was developed by the MPD and by the system leaders. California has a similar standard, and there are some national standards that are rolling out. Washington is definitely in the lead in developing these and rolling them out statewide. They're optional, so each system can pick which ones they're going to follow. They do allow some comparison between systems. The idea is that you should be able to compare apples and apples. And so here are some examples. It's not all of them, but these are things that I think we can pretty much all agree are good things. So scene time, 10 minutes or less. And then we understand if there's a prolonged extrication, you're going to document that. And that's part of that. But that's one thing that we agree makes a difference in survival from trauma. And then transporting trauma patients to a trauma center is proven to make a difference. For heart failure, so to either get CPAP if you're having respiratory distress from CHF, or have a contraindication documented, that's something that we know affects patient outcomes. To give nitroglycerin or to document a contraindication, I'll give you the evidence is weaker than it is for CPAP, but there is some evidence that that prevents mortality. So for asthma, patients with bronchospasm who get a beta agonist. I can tell you, I looked at this. We do great with this. This is probably not something we're going to spend much more attention on because we're there. Seizure patient management. Patients still seizing who get a blood glucose check. That's pretty uncontroversial. And patients who are still seizing who are treated with benzodiazepines. This is something we have good randomized controlled trials. People who get pre-hospital benzos for status epilepticus die less often than people who don't. So those are just some examples of key performance indicators. We'll focus on different ones at different times, and we'll report back to you to let you know where we stand. So I want to talk about cardiac arrest just a little bit more as a lead-in to what Dr. Whitwer is going to talk about. We talked about benchmarking. There are huge variations across North America in how well people do with cardiac arrest. So this is from the ROC trial, and this is published in 2008. So this is kind of right when the ROC trial was starting, the first few years. So in an area of fairly rural Alabama, overall, all EMS treated out of hospital cardiac arrest, survival to discharge 3%. At that point, Seattle had 16.3%. In patients with VFib arrest, this area in Alabama, 7.7. Seattle at that point was 39.9. We were part of the Portland metro area for that. So at that point, we were at 10.6 overall survival to discharge for all cardiac arrest and 22.5 for VFib. So that's kind of where we're starting. You can see there are huge variations across the country. So these are the trends. This is just by, and these are in ROC communities. And when you look at non-ROC communities or patients that, or areas that don't have a registry like CARES, we're lucky enough to have both. This is what's happening in patients that are actively studying cardiac arrest. So essentially starting from where we were around there. So this encompasses roughly those first 2 years of the study. So now in all of these areas nationally, as of 2010, survival from VFib was 29.3%. Survival from all cardiac arrest, 10.4%. So there's been a steady increase in survival because we've been studying this, because we've been measuring it, and because we've been working on improving the processes. And so this is a recap of what we talked about over the first 8 months of 2014. So 130 resuscitations attempted overall. So of all cardiac arrests, 19 patients survived to hospital discharge, so 14.6%. But I always have to remind myself as we look at these numbers, 14.6% just doesn't mean as much to me as 19 people who are back with their families. And then for VF and VT, 9 survivors. Of those, 8 were CPC 1 or 2. CPC 1 is completely neurologically intact. CPC 2 is a mild cognitive deficit, like some problems with short-term memory. There's one survivor who is CPC 3, so is requiring some occasional assistance with activities of daily living, but almost 43%. So that's a tremendous accomplishment. But what is possible? So here's a paper published 3 years ago in resuscitation from an area in Sweden. They have really good, really high rates of bystander CPR. They're at 25% for all rhythms and at 48% for VFib. And Seattle, I haven't viewed the data, but they're reporting now upwards of 50% for VFib. So that's all I have. I'll turn it over to Dr. Whitwer. Thank you.
So I think one of the there's a couple of takeaway points that I want to mention before I get on to the actual science and stuff, and from Dr. Mock's comments, is that you might ask, why do we have so few VFib arrests? That's basically the way it is. We have about 20% or less of persons present in primary VFib. And so one of the ROC and Heart Association and CARES measurements is separating VFib arrest, which is the treatable arrest, from all comers. The other got the PEAs, the asystoles. Now, we get some return of spontaneous circulation and some survivability from that group, too. So the overall all comers is about 16% in Clark County. The VFib arrest survival is about 43%. Now, in comparison, Seattle reported last year about 56%.
Can I update that? As of the last meeting, the experts said they were closer to 70%.
Now, just like the survivability, though, in Sweden, yeah, just like the survivability in Sweden and in Norway, being part Norwegian, I know that it's impossible to determine the CPC code in a Norwegian. You know, it's somewhere between 1 and 5. So you don't know about, whether they're brain dead or not. The other thing I want to mention is one of the things we need to make the KPI system work, we need data. And we need to get good data from you. We need accurate and complete recording of on your charting. We need to know things like whose monitor this is. We're going to review the monitor. We need to know things like we need to have you time the shocks correctly, like you're doing. We need accurate data. And then we're going to be getting, as Dr. Mock alluded to, we will be tying the hospital chart within it. We can tie the hospital chart now with your record by hand, but we're looking, because we go in and pull the charts, review the charts, get the data out of it, and bring it back. And we've been starting to get more and more data. All your cardiac arrests that are coming in now from AMR and Vancouver Fire, we'll be getting results back to you. Now, in the long run, we want to be able to electronically tie the chart, the hospital chart, to your chart so that we can talk back and forth quickly and easily. Okay, on to science and cardiac arrest. These are the basic 10 principles of high-performance CPR. The EMTs own the CPR, and that'll become more evident in a little bit. Minimize interruptions CPR at all times. Very little pauses, 10 seconds maximum. Ensure proper depth of compression. Ensure full chest recoil and decompression. Proper chest compression rate. Rate should be between 100 and 120 per minute. Rotate compressors. Hover your hands over the chest during the shock administration. You're ready to compress as soon as the patient is cleared from that shock. Intubate. Place advanced airway with ongoing CPR. So you don't have to intubate everybody. You don't have to place an advanced airway. But if you do it while CPR is going on. Place an IV or an IO with ongoing CPR. Coordinate between the EMTs and the medics. The EMT owns that CPR. In Seattle, they get angry if the patient doesn't survive because they know the paramedic did it. So, basic CPR, unresponsive, establish unresponsiveness. We get the check for pulses, lay persons don't. Pulses, apneic, begin CPR. You know how to do CPR. We're going to practice more, of course. Now, CPR is the foundation of a successful resuscitation. High-performance CPR improves effectiveness of that defibrillation. High-performance CPR improves the effectiveness of medication. I'm going to mention medication toward the end of this. Well, the problem is, why do we keep practicing it? Tom Ofterheide and others showed that what we think we do, we don't always do until you continue to practice and continue to have it observed by a dispassionate observer. We think we do a good job with the duty cycle, which is the actual compression, the compression depth, the rate of compression, and complete recoil, but they were all performed significant. He checked paramedics, he did EMTs. They said, oh yeah, we do great, 100% CPR. We always have good depth. We have good, we're doing 100, 110 per minute. And it didn't turn out that way until you practice and you continue to observe. One of the reasons that we ask people to put on metronomes is so they keep with that beat. You can't play music on the side. Usually people don't like that. Now Wick, who happens to be Norwegian, showed that trained EMS providers still, unless they only did about 50% what they thought they did when you actually observed them in practice, until they were refreshed. Basically, Seattle, and I keep harping on Seattle, but it's kind of the gold standard right now. Every day when you come to work, you do a basically a mega coat, the whole team, and they practice that. And those guys, I mean, I've watched them. You can set them, and they do a perfect 110 per minute, if that's what they're aiming at, over and over and over again. Just practice. The likelihood of return of spontaneous circulation increases with higher mean compression rate. So the hospital study showed 75% of patients received ROSC if they had 90 or more compressions per minute, compared to 42% with 70 or fewer. Now, we know that's true because we've seen hospitals do CPR. You want, right now, if you're going to have a heart attack, if you're going to have a sudden cardiac arrest, do it in front of a station, a fire station, or in front of AMRs. I mean, don't do it in the hospital. We're working on it. Hospitals are working vigorously to come up to our standards, because the evidence is clear. So, better compression leads to better organ perfusion. So they end up with better resuscitation. What organs are we having to perfuse? Well, the most important ones is the heart and the brain. Greater depth of compressions, increased likelihood of successful shock because of your perfusing the heart. The initial, when you have your initial arrest in VFib, your heart isn't out of substrate. It isn't out of ATP at that point. But after a short period of time, it runs out of ATP. How do you get ATP? How do you get energy back to the heart? You perfuse the heart. Oxygen, blood flow. How do you perfuse the heart? You perfuse the heart during diastole. The coronaries flow during diastole. When is the diastole in CPR? The diastole in CPR is when you allow recoil. Compression increases intrathoracic pressure, ejects blood from the heart and lungs, makes forward output from the heart and blood pressure. Decompression, the recoil, decreased intrathoracic pressure, refilling of the heart and lungs, and flow through the coronaries. Good recoil essentially makes vacuum in the chest, decreased intrathoracic pressure, sucking blood into the chest. Also, sucking blood back down the aorta into the coronaries. Well, I needed a, do I have a, I don't think I have a, my laser pointer somewhere here. There we go. Okay. Well, you have to look at this thing. This shows basically the hemodynamics of CPR. Avoid the bar on the far left-hand side, which just shows low blood pressure, low 0 to 20, intermediate 15 to 20. Oh, good. I can point with the mouse. There we go. 50, and then high at 40 to 150. Well, that's ridiculous. So during that is high blood pressure. So CPR, during compression, right here, your red line, aortic pressure rises to a peak and then begins to taper off, but it still has quite a bit of pressure, starting from about a low of 35 or so. It may rise as high as 60. Your left ventricular pressure, of course, reflects that too. It rises, but then it falls quite a bit lower because it doesn't have any pressure basically in diastole or in systole compression. It won't have much in the way of pressure at all because you're beginning to pull a negative pressure as you recoil. And your right atrium, why do you think of the right atrium? Because that's where the coronaries empty into. So you've got right atrial pressure rises as well because your compression is on the chest, and then it falls low again as you begin to bring the vacuum in the chest. Now, in the decompression, where you have actual vacuum, you have a difference between the aortic pressure, which is, say, roughly 40, and the right atrial pressure, which is 0 to 5 or 10. That difference is what causes the flow into the coronary. And also, the difference reflects basically what is the perfusion of the brain, perfusion of the heart. Now, you need to have an adequate systolic pressure to drive that blood forward to the brain, but then to flow through the brain, you need to have a low venous pressure to make it flow. So, but think of this as this equation right here. This difference here is what makes blood flow in the coronary, and that's what we're after to start with. At the same time, we have to keep thinking that we have the flow going through the brain. So, pausing makes a difference. The longer the pauses in chest compression, the lower the chance of your positive outcome. In other words, the lower the chance of an ROSC. The longer the pause preceding a shock or following a shock, the lower the chance of survival. This is a study reported in Circulation showing that if there was 3 seconds of pause, they had 100%, almost 100% successful resuscitation of their test animals. 10 seconds of pause dropped to about 80%. 15 seconds of pause to 40% survival. Why is this? Because as you continue doing CPR, good compressions, no pauses, that systolic number keeps building. And the aortic pressure keeps building, and see the difference now between the aortic pressure and the right atrial pressure. So as you stack your compressions, continuous compressions, you get up to a peak of compression cycle which allows you to have a good flow. You need at least probably 25 millimeters of pressure, 15 to 25 millimeters of pressure to drive the coronary. So at this level, you can see that you've got a really good gradient between aorta and the right atrium. You've got good flow. Now you stop CPR, and this little thing drops to nothing, and so does your aortic pressure tapers off. So if you have just a 3-second pause, you've dropped this aortic pressure, coronary flow, by a third, or by 2/3, right there. And if you make this go out for 10 seconds or more, you have no difference between aortic pressure and right atrial pressure. And you have to start over again. This is why many systems, ours included, have gone to continuous compressions. Don't stop for that. How long does it take you to put two breaths interposed? About 3 to 4 seconds. So put the breaths, just put them in while you're doing CPR, compressions. Now, decompression is important. Incomplete decompression, inadequate blood volume in the heart and lungs. Yiannopoulos and others show, and this is science, 75% decompression doesn't provide sufficient coronary flow or sufficient cerebral perfusion to allow ROSC. inadequate decompression comprises both compromises both coronary and cerebral blood flow. Even if you limit the periods of incomplete decompression, and then the next guy gets on and does a really good job, no camping on the chest, as the Canadians say, you don't catch up. What this shows. So coronary perfusion pressure, you have 100% chest recoil, good coronary perfusion, good cerebral perfusion, or adequate, still only in the 15 millimeters of mercury. Here, this is almost 25, so that's good. When you go to 75%, you drop to 15 and below. That's not enough to do adequate flow. And then when you catch back up, your next duty cycle, you never rise above about 15 or 16 millimeters. You just don't catch up. It takes a long time to catch up. So, how does this affect medication? And this is begging the question whether medication makes any difference. But we're going to think about that. So perfusion is the mechanism that circulates medication, so the better the perfusion, the better the medication goes around. Good CPR decreases the amount of time it takes for epinephrine to reach peak concentration by about a factor of 2. So if it takes 1 minute of poor compressions to circulate epinephrine, get it up to peak load, then it only takes half a minute, 30 seconds, to do it if you're doing good compressions. So better CPR is decreased time to circulate. That will likely increase the effect of the medication if the medications make any difference in the long run. So, yep. I think they'll give 2 options, my guess is, because I think they will recommend, that they will say that depending on how you're trained to, I don't know, and I was hoping that they've already been having the meetings. They're going to have some rollout stuff among themselves this next month and in March, and I'm hoping it would come out in March, but I've been around long enough to know that the AHA guidelines won't come out until November, probably just before the science sessions. This graph illustrates what we've just been talking about, though, that if you have good CPR versus poor CPR, you get better effect of coronary and cerebral perfusion flow with epinephrine. Now, why does that work? Well, because epinephrine is going to raise that systolic pressure, raises the diastolic pressure, which by causing vasoconstriction. So you increase the diastolic pressure, you increase venous flow during diastole. Okay, now here's a bit of science, and we'll point out that this is one of the results of the rock studies. That one of the things with the rocks, we do write a lot of papers, drilling down, culling the data out. And Myron Weisfeld was a very funny old guy. Was the head of this one, but a couple of us were also on the writing group on this. And this one is an assessment of hospital care and functional survival of initial VTAC, VFib arrest patients shocked by bystander AED versus patients shocked by EMS. So, 2 different groups, VFib in both groups, but bystander CPR and an AED, and bystander CPR, but no AED, and EMS was the first delivering the shock. AED shock by bystanders associated with greater survival with good to excellent functional recovery. And here's the thing, it results in less use of medications, any medication, including epinephrine, to achieve stable hemodynamics after the arrest. Now, that basically means that the quicker you can get ROSC, the less likely you're going to use epinephrine or anything else. The less likely you're going to require it. So, good ROSC and a quick shock is the way to go. Remember, Mo Daya has another paper not published yet that shows that across the country, if you have bystander CPR and an AED, you have a 25% chance of survival versus 7% across the country if you don't. Another study, IV drug use during out-of-hospital cardiac arrest. Do drugs work? Well, in this case, they used cardiac arrest and they broke them into two groups. ACLS with an IV start plus drugs, and the drugs were everything that's in the box. So could be epinephrine, could be epinephrine plus amiodarone, could be epinephrine plus lidocaine, didn't make any difference. IV plus drugs. ACLS without IV or drugs until 5 minutes after ROSC. So if they got ROSC and the person was low blood pressure, they were able to start them on dopamine or norepinephrine, whatever. Then the patients got standard hospital care with hypothermia. They went to the cath lab, etc., if needed. And what were the results? Well, with drugs, they got 40% versus 25% ROSC. Okay, lots of ROSC. Admitted to the ICU, 30% versus 20%. So significant, and this is these P numbers, don't think anything with a really low number, 0.001, is statistically significant. But then look at this one. Discharged alive and discharged alive and alive at 1 year. There's literally no difference, and there's no statistical difference between them. Now, obviously, with 400, 500, 800 people in the cohort study, that means there's one or so live person different. But that is not that's within statistical variation. In other words, did the drugs make it? Not apparently. So what are we doing with all that? Well, okay. Here's the Japanese study. Huge study, retrospective study. Japan had it because it's a national health system. They get to look at all the cases. You don't have to ask your permission to look at your chart. I think there's somewhere in the neighborhood of 400,000 cardiac arrests. Their answer was use of pre-hospital epinephrine was associated with increased ROSC, decreased chance of survival, and good functional outcomes 1 month after the event. That was their endpoint. They said, hey, did more people go in? And it turns, and if you got epinephrine in the field, you were less likely to leave the hospital than if you didn't get epinephrine and you got to the hospital. Now, tuck that away. Another, just recently, this one comes out of Europe. In this large cohort, I mean, big, evenly matched group who achieved ROSC, pre-hospital use of epinephrine was consistently associated with a lower chance of survival. It showed dose effect, which meant the more epinephrine you gave, the less likely you were to survive, and persisted despite post-resuscitation interventions. Now, does that mean we're going to throw out epinephrine? No, not yet. What this means is, and you just have to go back to that initial study that I said that if you got early ROSC because you got good bystander CPR and an early AED shock, so you had less likely chance of getting medications. So this makes sense. The quicker we can get ROSC without medications, the better off that patient's going to be. That means they've got a downtime that's short. Now, we still use epinephrine. We still recommend epinephrine because we do get more ROSC. So if you're 10, 15 minutes down the line and you're getting ROSC because you get an epinephrine, that patient logically has less, they've been down a long time. They're going to have less chance. They're going to have more reperfusion problems, and we haven't solved the reperfusion issues yet of the brain. So they're going to have less chance of survival than someone who reacted after the first shock. The person that Marlon gets a shock, he's talking, gagging in the tube, and he starts. When they hold you away from the second shot, you've got a winner. That person's going to, do okay. What about hypothermia, pre-hospital hypothermia? Okay. 2 studies, best ones, one published in Resuscitation in 2013 by Dial, and then Kim, who's the Seattle study, big study, published in JAMA last year. Pre-hospital hypothermia effectively cools the patient. You guys do a good job. There's no problem cooling the patient. But it didn't improve survival or neurologic outcome in any arrest situation. So there's no point in messing around. That's why we took it off the regs, and we'll let the hospital do it. The hospital still does really quick hypothermia in indicated cases now. And there's no point in giving you more work to do. I want you to do good CPR instead and get early ROSC. Yeah.
Has there been any show that what they're doing in the hospital is
More effective than? No. But
I mean, is the result of the hospital showing?
yes. Yes. We're still looking at a significant statistical advantage to doing the pre-hospital or the hospital cooling, and it's sort of juggling around. There are algorithms that do it for 12 hours, there are algorithms that do it for 18 hours, there are algorithms that do it for 24 hours, there are algorithms that do it for a day and a half before you try to warm the patient up to see if they're neurologically okay. Well, the core temperature is not significantly down. Matter of fact, sometimes the core temperature is a little high. People don't do well. I mean, your brain kind of reacts. Hypothalamus kind of reacts negatively sometimes to have an arrest occur and then resuscitation, because you got reperfusion things going on, and people will sometimes run a fever. So I think the core temperature is pretty, unless they're laying there totally naked in the back of your rig and it's -2 outside in Alaska. So teamwork for resuscitation. Teamwork's the key. Coordinate, collaborate, communicate. We're increasing the focus on a team approach during resuscitations, because all these interventions, all these things have to occur simultaneously. You want to minimize your interruption and compressions, and with good, clear communication and pre-planning, you minimize errors. That's why we're going to do more and more practice of CPR. We're going to try to push that 43%, 44% to 50% or better for VFib arrest. High performance CPR, the foundation is EMT CPR. Advanced cardiac life support has to be layered on top of it, and that requires teamwork. So basic EMT CPR, compress more than 2 inches, minimize interruptions, full recoil, a rate between 100 and 120. Switch compressors every 2 minutes. Hover the hands, be ready to start the minute the patient is cleared, either by a shock or by dumping the shock and say patient's clear. Prioritize your compression so it's circulation, airway, breathing. Now, advanced things include rapid rhythm analysis. If you have an all EMT crew, they're using an AED. But paramedic advance is visual and a rapid rhythm analysis, minimize the pauses, administer drugs as needed with an IV placement, intubation as required. That's down the line. Vancouver Fire particularly is going to what we call the pit crew, and we have a tape to this. And the pit crew approach is basically one way of organizing this. So, and I'll tell you right off the bat that Vancouver's plan is, and that won't work for every agency, it won't work for every district. Vancouver's plan is to run 2 crews to every assumed cardiac arrest. So they'll have with AMR arriving too, they'll have as many as 6 to 8 persons on this cardiac arrest at any time. Now, obviously, in places where you don't have that plethora of folk, you may only have 2 people show up to the arrest, and you have to modify your approach by that. So we're going to talk about pit crew. We're going to show you some video on it as well. It's just an organized way of managing resuscitation. You have predetermined assigned patient responsibility. I think there's a handout in the back. But the number one priority of all personnel is to maintain high quality CPR with minimal interruptions, no interruptions beyond 10 seconds. The pit crew approach has to be adapted. And you have to, and of course you can't do pit crew if the patient is down and in a bathroom that's 6 by 8. You can't do pit crew. You've got to get them out where you can work on the patient and do resuscitation. If you limit your rescue, CPR and defibrillation are the first priority. All other activities can wait for other resources. You don't have to put an advanced airway in. You don't have to put, if you only have 2 people, you don't have time to do all that stuff. You don't have the ability to do that. And then, of course, with fire, you have to follow incident command principles. First arriving paramedic is always the team leader for the resuscitation. Doesn't make any difference if it's a fire paramedic or an AMR paramedic. First arriving company officer, this is stuff beyond my ken. The fast attack incident commander, la 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 la. Second arriving company officer is the strategic incident commander, la 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 la. I'm going to let Jay and those guys talk about it. You guys in the fire know, you know what that's all about. And of course you require a lot of people to get, that many company officers. Position 1, compressions, determine cardiac arrest, exposed to chest, begin compressions, announce when you get the compressions, 180, 190, and 200. That way you can trigger the AED or the defibrillator. Second person turns on the life pack to start the timestamp. Start the metronome if your crews are using a metronome. Apply defibrillation patches, monitor compression quality, speed, time. Charge the monitor at compression 190, interpret rhythm and shock if indicated. And then alternate with the compressor because you need to switch at 2 minutes. Notice nothing said there about airway. They're not out of air at that time. Position 3, now you're starting to get more people showing up. Or if you had a 4-person crew arriving, you've got them already. Oxygen at 10 liters, even without the bag valve, unless the patient has an airway obstruction, which you're doing a different kind of cardiac arrest at that point. If you have normal airway, high flow oxygen, you get a gradient between high level of oxygen, low level of oxygen, lower level in the lungs, and you get actual flow of oxygen down the tube into the trachea into the alveoli. So you will maintain, even without doing bag valve. If you've got somebody there to do the bag valve, fine. If after the first or second defibrillation, the EMT, and we train the EMTs to insert an eye gel if that's appropriate. If you need to intubate the patient because of airway control, that's the paramedic's job. As the paramedic arrives. We'd like to have the ETCO2 monitor on. We're using that to determine whether we're doing good CPR and whether we have return of spontaneous circulation and whether the patient is obviously dead. Hopefully none of you are carrying that particular IO anymore. Position 4 will alternate with compressions. Position 5 starts an IV. You get one IV attempt prior to the IO by a protocol, or if your IO it can be done early if you know it's going to be unsuccessful. Okay, about a minute at a time, but that requires another person. Position 6, the safety liaison with family doesn't do anything else, develop the egress plan. Position 7 or 8 are assigned by the paramedic in charge as it happens. Now you can see if you get 8 people, you can really buzz right through this, but you have to kind of know where you're going to go as you start. And that's what pit crew is all about. Pit crew comes from the idea that how do those guys change all those tires and gas it up at those pit stops because they all have assigned jobs. And they practice them. They practice. So this was the handout. So it's your position 1 on compression. Position 4 drops in after you get 4th person. Position 2 does the life pack. He's the team leader generally. Position 3 comes in and takes over the airway. Position 4 is here. Position 5 is the med kit. And these are the backups, including the strategic incident commander who starts getting things going. After the incident, company officers should debrief the crew after each cardiac arrest and call and determine where you can make improvements. All personnel should review the CPR process file after the fact. So we are going to have to get to the point of being able to have the company officers or the paramedic be able to download and bring up that CPR process file. So just to recapitulate before we go, EMTs own the CPR, minimize interruptions, ensure proper depth of compression rate, a proper chest compression rate, rotate compressors every 2 minutes, hover over the chest so you can start minimal interruptions. It says 10 seconds or less. I'd like to see less. Now, sometimes you can't be sure that it's a VFib. You know, when you look at it, is this VFib? Is this not VFib? Intubator place advanced airway with ongoing CPR. Place your IVIO while ongoing and coordinate. This, just to refresh you, is what a CPR process file looks like. All these little red things, and it doesn't show the depth. All these little red guys are compressions. So you can see, and this is a minute. Each line is a whole minute. So you got 10 seconds in each thing. And you can see here, here's a pause, and this pause goes for about 14, 15 seconds. This pause here is really nice. This only goes for a few seconds. But then there's another pause, which we don't know why until you write into the narrative what happened there. That way we can check it and see. So some of these pauses are longer than 10 seconds. So this line here tells you your hands-on chest ratio. It's a CPR rate. So it takes the number of compressions per minute, factors out the time of pauses for each minute. So in this minute there was 77% hands-on. This minute 100% compression rate. This minute 70, and this 100. So this is not too bad. This one shows how fast your compression rate was each minute, and this is right on the money. A little fast down here, but not too bad. It probably varies by the compressor, changing compressors. This is the total compressions given over a minute. So 88, 112, 88. So this is the compression rate minus the time off the chest, the pauses. This then is the dashboard, and this is the quick thing to look at. This shows you your CPR total ratio. It's in the green, which is good. The compression ratio is in the green, which is good. We'd like to have it closer to the 100. And the compressions per minute, right on the money, 100. So you go over this stuff, and you see, because you know who was on the chest during those 2-minute periods of time, you can say, you need to increase your compression rate a little. But for following the metronome, that shouldn't be a problem. Oh, you took a little time. How come it took you 15 seconds to determine whether this was V-fib? That happened. We need a read. We're not penalizing. We just want you to get closer and closer and closer to the gold standard. Jay, do you have that? Let's see. We have the. Okay. All right. Now I got to get out of. Bear with me here. It's still. Okay. I'm going to end this. Get to the desktop. Okay, where is it there? Okay, wait a minute. No, KPIs. Okay. Okay. Minimize that.
Then we've got Mike. What's it called again?
Mike, what do you call it?
It's that one on the far right.
County CPR, right there. Okay. Play.
This is Clark County's EMS pit crew model for high-performance CPR. This will be based on our three-rescuer model.
The first
where
one
fire
is a
response crew arrives first.
3 rescues. 3-person rescuer to start with. If you have
Using
3
the skill
persons,
sheet that you have in front of you, we're going to identify 3 key positions that need to be filled.
And airway.
Rescuer 1 will fill the role of compressor, which is a BLS position. Rescuer 2 will fill the role of ALS position. This is also the resuscitation leader position. Rescuer 3 will be the airway position filled by a BLS personnel. As additional resources arrive, Rescuer 4 will fill backup compressor role. Rescuer 5 will be IV/IO medications, also a paramedic. Rescuer 6 will be in the IC, which is a company officer. Rescuer 7 will be additional resources, and so will Rescuer 8. This is the organized approach, or the pit crew model, to cardiac resuscitation. This This diagram shows the ideal equipment placement during a pit crew resuscitation. The airway kit and suction near the patient's head, the life pack near the patient's shoulder, and the med kit near the patient's lower extremities. Here, we're going to watch as the 3 crew fire responders arrive to a patient's side. Rescuer number 1, the compressor, determines cardiac arrest, exposes the chest, and begins compressions. Rescuer number 2, the ALS member, turns on the monitor to timestamp when CPR began. This rescuer also attaches the fast patches and connects wires to the monitor, also assuring it is in the paddles mode. The metronome is also turned on as well. Rescuer number 3, the BLS airway person, is placing a nasal cannula and can place an eye gel as needed. Because additional help has not arrived yet, rescuer number 2, the ALS team lead, is beginning the duties of position number 5, which is the IV/IO and medications position. As rescuer number 3 now begins to ventilate the patient, particular attention is now spent making sure that ventilations are delivered on the upstroke. As AMR arrives, rescuer number 2, the resuscitation leader, delegates the unfilled positions. The AMR medic will fill position number 5, which is the IV/IO medications role, while the BLS crew member will assume position number 4, the backup compressor.
The black gloves have arrived.
When a 2-person AMR crew arrives first, or a 2-member squad or a quick response unit, positions 1, 2, and 3 are filled by 2 people. Rescuer number 1 determines cardiac arrest, begins compressions. Rescuer number 2, the life pack, turns on the life pack, but now assumes rescuer number 3 position, airway. The monitor has been time-stamped when the compressions begin. So at this point, he can leave the monitor and begin the role of airway by putting on a 10-liter per minute nasal cannula, finish hooking up the fast patches to the monitor, attaching all wires and leads to the monitor, and turning on the CPR metronome.
He's going to have to get all that done in the first duty cycle.
As fire first responders arrive, they will automatically fill positions 3, 4, and 5. These are airway, backup compressor, and IV/IO medications. The first arriving paramedic is the team lead for resuscitation. Here he is relieved by a BLS personnel at the airway. allowing him now to be resuscitation leader for the remaining code. To summarize some key points, remember we are now placing a nasal cannula at 10 liters per minute during a cardiac resuscitation. An eye gel is an acceptable initial airway device. Practice upstroke ventilation. Minimize interrupting the chest compressions. BLS owns the code. And utilize the LifePak metronome.
Okay, any questions? So you get to practice next month. Now, yeah. You can certainly leave that if you have enough thing. When you go to the bag valve, you should probably switch O2. Although, we don't have any good evidence that high flow oxygen makes any improvement. Matter of fact, it may make a negative thing in the long run. We don't know that. We don't have the evidence for it. If you have enough, you should have enough. Well, when you have the eye gel in there, you sort of effectively block that nasal cannula, so you have to switch. If you were just using a bag valve, I just leave that in there. If you have an ET tube or an eye gel, yes, you've got to switch to the bag valve because you're bag valving and you're effectively blocking that nasopharynx off from the rest of the airway. So let's take a 10-minute break, and then we've got more things to come.
Make no delay. Come from every nation, come from every way. Our lands, they are broad enough, don't be alarmed, for our Uncle Sam is rich enough to give us all a farm. While the South shall raise the cotton and the West the corn and pork,
New England manufactories shall do up the finer work.
for the deep and flowing waterfalls that course along our hills are just the thing for washing sheep and driving cotton mills. Then come along, make no delay. Come from every nation, come from every way. Our lands, they are broad enough, don't be alarmed, for our Uncle Sam is rich enough to give us all a farm. Yes, we're bound to beat the nations, for our mottos go ahead, and we'll tell the poor and paupers that our people are well fed. For the nation must remember that Uncle Sam is not a fool, for the people do the voting and the children go to school. Then come along, make no delay. Come from every nation, come from every way.
Back in business. Okay, couple things that we're going to go on to, well, right now to the Zoll Life Fest, and we're going to go on to some other areas of interest, including the ALP study and the usual kind of stuff, and then we have case reviews. So lots of things coming. More news at 11, like they say. Okay, why talk about the Zoll Life Fest? Well, we checked, Mark informed me that Mandy, the representative for Zoll Life Fest, which is a wearable cardioverter defibrillator, just something you get, every well-dressed man should have one. There are 12 of them in Clark County active right now, and there are 6 or 8 of them in Cowlitz County active right now. These are temporizing measures. These are wearable defibrillators that the patient wears until, generally speaking, until they have an AICD, an implantable defibrillator put in. There are reasons medically why you wouldn't have it put in right at that time, well, whatever. But these are wearable. There was one, as a matter of fact, one of our young patients, a 16-year-old who was resuscitated, wore because the cardiologists at OHSU could never initially figure out what was wrong with her, why she had a cardiac arrest. So they put a wearable defibrillator on her for about 2 to 3 months before they finally tumbled to what was going on and then put in the implantable AICD. So, wearable defibrillators are for patients who are at risk for sudden cardiac arrest. The temporizing device, non-invasive, the garment, and it's a garment and a monitor. The garment detects arrhythmias, delivers treatments and shocks. The monitor monitors the rhythm and contains the battery. You can be shocked by the life vest, so you need to know about it. You know, if you're touching the patient while the thing goes off, you'll get a shock too. Now, will that fibrillate you? Could be. So you have to be careful. It'll certainly get your attention. So you don't touch the patient while the life vest is delivering a shock. And how do you know that? Because the life vest warns you. It has a siren alert and a voice command saying, electric shock possible, don't touch the patient. Shock possible, don't touch the patient. Or, bystanders do not interfere. So just keep your lip, hover at that point. Can you use external defibrillation while the patient is wearing a life vest? The thing isn't working and the patient needs to be defibrillated? Yes. You should disconnect the monitor, though, because if you give it 200 to 300 watt seconds across the chest, you'll also fry the monitor. These things are relatively expensive. If the patient says to you, I feel a vibration coming from the garment, that's usually along with an alert, voice prompt. It's part of what they call the consciousness test, because it'll vibrate so the patient feels it and it'll talk to them, and then they know that they're not dead at that moment, so they can push the response buttons to avoid a shock. If the thing identifies that there's if the thing identifies VFib, it shocks the patient without warning him. They'll tell you that. Now, sometimes the patient know they're going to, like guys go into, I had several patients who go into frequent VFib or VTAC, and then they go to VFib, but VTAC, and they say, and then they get a shock. Don't touch that patient either. Now, there's other things. If the device is silent, or it may say, contact a physician, or treatment is given, call your doctor, that's a single alert tone. You don't have to. The device is monitoring the patient, and it may be alerting the patient to follow certain instructions, and there's an instruction on the screen. There's a two-tone siren alert. The voice will say, if the patient's not responsive, call for help, perform CPR, or device disabled, call an ambulance. That means the device can't detect the ECG or it's delivered the maximum number of treatments. It's set for, I think, 3 successive shocks or 1 shock every, so, when you get enough shocks. Now, sometimes the things go nuts and they start giving shocks. Just like AICDs go nuts occasionally. As I was speaking with TJ the other day, TJ Bishop, and I have never personally had to treat a patient who had an AICD go bad. A couple of my partners say, yes, I've had to put a magnet on an AICD before, but usually the magnet stuff, I've never even, in the last 10 years, I've never had to put a magnet on a malfunctioning pacemaker either. So these devices are much better than they used to be, so they seldom go bad. Two-tone siren alert says, don't touch the patient or bystanders don't interfere. those are the ones where you want to stay off the patient. That means it's detected the ventricular dysrhythm and the device is preparing to shock the patient. Stop CPR at that point. If the patient's alert and responding to that, why are you doing CPR then, right? The patient can push the buttons. So if you have to do standard evaluation and treatment measure, you can do CPR as long as the device isn't saying, get away from me. Treat the patient with an external defibrillator. You can take the life vest off, but you first pull out the battery, because if you take the life vest off the patient, it starts alarming right away because it thinks it's lost ECG. So disarm it by pulling the battery out. Now, Mark assures me this will work. I'm going to hover for a second or two. Well, maybe I hovered too long.
The following video will provide a brief overview of the LifeVest wearable cardioverter defibrillator and includes information that will be important for you to consider in the event that you encounter patients wearing the device. LifeVest is a wearable defibrillator that offers at-risk patients protection against sudden cardiac arrest. Unlike an implantable cardioverter defibrillator, the LifeVest is non-invasive and is worn outside the body rather than implanted inside the chest. The LifeVest consists of two main components, a garment and a monitor. The garment is worn under clothing. It detects arrhythmias and can deliver treatment shocks to the heart when necessary. The monitor is worn around the waist or from a shoulder strap. It monitors the heart, records arrhythmias, and determines when treatment is required. Electrodes are contained in the belt around the body. ECG electrodes continuously monitor the heart rhythm. Therapy pads deliver treatment shocks to the heart when necessary. Tens of thousands of patients have been protected by the LifeVest wearable cardioverter defibrillator since the device received FDA approval in 2001. The LifeVest is used for a wide range of patient conditions or situations, including following a heart attack, before or after bypass surgery or stent placement, as well as for those patients with cardiomyopathy or congestive heart failure that places them at particular SCA risk. Patients who have had an implantable defibrillator removed and are unable to be immediately reimplanted for whatever reason are also prescribed the LifeVest for protection until the reimplantation procedure. The LifeVest has two models shown here. Though differing in appearance, both models are equally effective at detecting ventricular arrhythmias and delivering life-saving therapy. The LifeVest system uses 4 ECG electrodes around the patient's body. One pair of electrodes provides a side-to-side channel of the ECG signal, and the other pair of electrodes provides a front-to-back channel. When a treatable ventricular arrhythmia is detected, the LifeVest initiates a sequence of alerts and voice prompts to warn the patient and bystanders of a possible treatment shock. During this time, if the patient is conscious, they are instructed to press and hold the response buttons, which are found in the top corner of the LifeVest monitor. The response buttons prevent a treatment shock from being delivered. Please note that only the patient should press the response buttons. If, however, the patient is unconscious, the sequence will run through a 5-second vibration alert, followed by a low single-tone siren, which is broadcast for 5 seconds, followed by 5 seconds of loud 2-tone sirens. The device then transitions to voice prompts accompanying the 2-tone siren. In order to quickly and effectively care for a patient wearing the LifeVest, it is important to understand the different alerts and voice prompts that may be broadcast from the device. If the LifeVest device is silent when you arrive on the scene, the device may be monitoring the patient's heart rhythm. If, however, you arrive on the scene and you hear a single-tone alert, or a gong from the life vest, the device may be alerting the patient to follow instructions displayed on the monitor screen. In some instances, the gong alert may also be accompanied by a voice prompt.
Treatment has been given. Call your doctor.
Or,
Contact physician.
in these situations, you should proceed with standard evaluation and treatment measures. If external defibrillation is available, a decision can be made to remove the life vest and monitor or treat the patient with your own external monitoring and defibrillation equipment. To disable the life vest, simply pull out the battery. You can then unclasp the hooks at the front of the garment and remove the device. If you arrive on the scene and the life vest is broadcasting alerts or voice prompts, it is important to pay close attention to these messages. Audible two-tone siren alerts and voice prompts may indicate that the patient has been treated or is still in the process of being treated. You may hear the two-tone siren alerts accompanied by one of these prompts.
If patient is not responsive, call for help. Perform CPR.
Or,
Device disabled. Call ambulance.
these prompts mean that the life vest may be detecting an untreatable rhythm, such as asystole, is unable to detect an ECG signal, or may have delivered the maximum number of treatment shocks in a treatment sequence. In these situations, proceed with your standard evaluation and treatment measures. You may decide to disable and remove the life vest and use your own monitoring and defibrillation equipment. Again, to disable the life vest, simply pull out the battery, then unclasp the hooks at the front of the garment and remove the device. If the life vest has detected a ventricular arrhythmia and is preparing to treat the patient, the two-tone siren alerts will be accompanied by this voice prompt.
Electrical shock possible. Do not touch patient. Bystanders, do not interfere.
When the life vest is in this mode, an electrical shock will be delivered between 25 and 60 seconds after the treatment sequence begins, depending on the type and rate of the arrhythmia and whether the patient presses the response buttons. Please note that you can be shocked if you are touching the patient when the shock is delivered. Do not touch the patient when the life vest is in this mode. Allow the life vest to complete the treatment sequence and shock the patient. The device will broadcast when it has completed the treatment sequence. The sirens will stop and you will hear the following instructions.
Treatment has been given. Call your doctor.
Blue gel on the patient's chest and back is an indication that the patient may have been treated. The life vest deploys blue gel prior to delivering a treatment shock. The purpose of the gel is to improve shock conduction and minimize burning. This gel should remain on the patient as long as they continue to wear the life vest. However, if you choose to remove the life vest and monitor the patient with your external equipment, the gel can be removed using water. The life vest system is a wearable defibrillator that continuously monitors the heart rhythm, rapidly detects sudden cardiac arrest, and responds by defibrillating the heart back to a normal rhythm. If you are required to treat patients wearing the life vest, pay close attention to any alerts or voice prompts that may be broadcast, and remember, you may proceed with standard evaluation and treatment measures as you deem necessary. Zoll provides 24-hour technical support for patients and healthcare professionals. For any questions about the life vest or dealing with life vest patients, please call us at 1-800-543-3267. You can also learn more about the life vest by visiting www.zoll.com.
If you encounter a patient with the life vest and you go onto that, then transport, if you take the life vest off, and leave it at home, don't leave it at home. Take it with you because they can interrogate the life vest. What they do is bright lights and sit down and, waterboard the thing. And they can interrogate it to determine what the rhythm was. That's important for the cardiologist. Okay, quickly. Mention ALP study. We are still in the ALP study. We are now in the 4-county area. Multnomah County not playing. We're at, I think, around 240, 250 patients entered into ALPS, which is actually just a little bit ahead of where we wanted to be at that time. So people are responding well. They're first of all, we had a lot of cardiac arrest during November, December, but they were entered into the ALP study at a good rate. We've had few, at least in the last couple of months, few cases not entered, and at least in Clark County. It looks like we'll be on track, though. The study will be done by the end of December this year, unless they stop it earlier, because they'll go back in soon and do another pass through the data and see if there's any arm of the study that should be stopped early. So inclusion criteria, though, remember, non-traumatic out-of-hospital cardiac arrest. When we practice the megacodes next month, we will include an ALPS case in there, at least one. Non-traumatic out-of-hospital cardiac arrest, you have to have IV access or IO access, persistent or recurring VFib or VTAC, which means by definition you have to have at least 2 shocks into that patient for VFib VTAC before you go to ALPS. Obviously, if it's unwitnessed, CPR for 2 minutes, analyze, shock the patient. CPR for 2 minutes, analyze and shock the patient. Then you can do epinephrine and ALPS at that point. Now you can get epinephrine and ALPS in the same duty cycle, but you have to flush in between. Witness shock, you follow the above procedure as well, but you start right off. A witness patient, though, you just start off with your initial. If you witness it, you do initial shock and then go from that point. Exclusion criteria: no open label amiodarone lidocaine used on this patient, either before or after ALPS. Obviously, we have protected populations that we don't do ALPS on, don't do any studies on, and those with the no study braces. To my knowledge, we've never had a no study bracelet pop up in Clark County. If you do, if the patient meets exclusion criteria, you do our standard ACLS treatment, which to this date still includes CPR for 2 minutes, analyze and defibrillate, epinephrine, and if you have persisting VFib, pulses VTAC, amiodarone is our preferred drug for whatever reason, and lidocaine is the next drug if amiodarone is contraindicated. You can always use magnesium in any case because it's not considered an antidysrhythmic. So, patients seldom meet exclusion criteria. What counts as a shock? Any ROC-administered shock, any first responder or BLS AED, any AED, public access AED, any ALS-delivered shock, life vest, and AICDs do not count as a shock because we don't know what that rhythm was that they shocked. So life vest and ICD shocks don't count. Study drugs should be given within 10 minutes or less. Actually, our timing is pretty good. It's usually better than that, but we need to push. So you can give it concurrently with epi, The dosing, as you recall, first dose is syringe 1A and 1B unless the patient's a little itty-bitty, teeny-weeny person. And the second dose is syringe 2. You have to use the ClearLink adapter because the ALP syringe is incompatible with your Luer lock. You put the ClearLink adapter on the patient's IV tubing first, and then you attach the syringe with a little half turn. If VFib, VTAC persists after you give the study drug, you can use magnesium. If you used all the study drug, you can use magnesium, additional shocks, additional epinephrine, no open label amiodarone or lidocaine. After enrollment, call that number that's written in your thing. You don't have to remember it. Notify the receiving facility of ALPS enrollment, even if they look at you dumbly and say, what are you talking about? Because they sometimes do. Marty and I have to retrain some of or update some of the folks. Critical to download your CPR process file. Note the time of ALPS drug administration. Note which unit's defibrillator was used. Okay. SUD study. This is informational for fire, mostly for AMR. SUD study is a genetic study of why people may be having sudden cardiac arrest. There does seem to be some genetic data out there that we may end up being able to do genetic testing and prevent sudden cardiac arrest in populations. And what we need is a blood sample for any patient who so for AMR, remember, any patient with a pre-hospital cardiac arrest, even if you get ROSC, but if it's a non-traumatic cardiac arrest or an overdose cardiac arrest, draw blood as soon as possible after your IV or IO start. We don't need a lot of blood. Label the tube with the patient's name, number, date of service, hospital face sheet if you have one. Put everything in it's got a supplied baggie and an ambulance cooler until they go to headquarters refrigerator, and then it's sent in to the SUD study. If you don't remember it, that happens. If you do remember, it's even better. That way we get it. All right. Marty. Now we're going to go on to some case reviews.
Okay. Can you hear me back there? Okay, so these are some examples of cases that are cardiac arrests or patients that have had cardiac disease. And this first one is, interestingly enough, is a life vest patient. He's awakened from his external defibrillator going off, but he's not sure, can't say if he was shocked one or more times. He thought it may have been a shock, but maybe it was his wife elbowing him. Lightheaded with some stabbing, kind of atypical pain around the side of his defibrillator pad. Had a recent MI, so had a recent infarct and was wearing the external harness, awaiting for an ICD procedure. That's his pertinent medical history of hypertension, congestive heart failure, and a recent stent, and discharged 2 days prior. So early on in his recovery. And this is the timeline here. He looked pale and was clammy, so signs of skin signs of something going on. His blood pressure was actually good with a good heart rate, and he had clear lung sounds. His pain, he was uncomfortable after the shock, 5 out of 10. 12 lead didn't show any evidence of STEMI. He was given some aspirin, and oxygen was applied, had an IV access, single attempt. Is anybody in the room that actually did this this response? Okay. Glucose was normal. Let's see. Had some sublingual nitroglycerin. Again, another 12-lead interpretation that confirmed no STEMI. Vital state relatively stable. And he was transported. In the hospital, he was admitted to the ICU and appropriately put on telemetry, which all these patients go on routinely. Had multiple episodes of VFib with conversion and was placed on antiarrhythmic oral amiodarone. He was discharged 6 days later after getting a ICD placement, and that was his hospital course. So some of these patients do not get immediate ICD placement. Some of the patients do. Some of it has to do with funding, I think, and meeting criteria that will actually be reimbursed for ICD placement. Those are the patients with cardiomyopathies and congestive heart failure, and to see if there's a window of opportunity. And that's why for a recovery after an event, so the payers won't pay for an ICD, because it is a rather spendy little Porsche that they're putting in the patient's chest. So, but this guy got an ICD placement after he proved that he was going to die. Patient number 2. This is geriatric medicine here. 83-year-old male, unconscious, agonally breathing. He was in a jewelry department. Probably the prices of the jewelry set this arrest off.
He was buying a new diamond for his 28-year-old. That's what really killed him.
So he was shopping, and I was having a conversation and just dropped to the floor. So it sounds like a sudden cardiac event from just the history of it. Employees assessed the patient and began bystander CPR and called 911. EMS arrived and assumed the responsibility of CPR. He was pulseless and apneic, and his sugar was 135. His end-tidal CO2 was 42. And here's the timeline.
The interesting thought of it, I'm wondering, does anybody know, does Fred Myers have
AEDs? They probably sell them.
Well, I mean, that's why Walmart has them.
Exactly.
They have a special, have a little tag on the bottom.
So the initial interpretation was VFib, and patient was defibrillated with 200 joules and had persistent VFib. He was given IO was started, I believe. Easy IO, yeah, right distal tib. And must have been, it says distal tib, but it's probably proximal tibia. Given epinephrine. Fibrillation again, so 300 joules, persistent VFib. And then I believe the ALPS medications were administered, ROC, ALPS. 1A and 1B, he must have been over 45 kilos. And then defibrillated again, VFib. This is a frustrating case because he's not had a return to spontaneous circulation. Had another shock. End-tidal CO2 is 42, so it's still pretty good. You know, you got to keep working this guy. Intubated with a glide scope. I imagine it was the King Vision. And had good bilateral breath sounds. Second dose of Alps. And then persistent, then he went to PEA after the next shock number 5, which is not good in terms of prognostic signs. Capnography is still good, even after another round of CPR and epi. And then refibrillates, PEA in and out of that. And then this does not look good. His CO2, end-tidal CO2 looks like it's dropped significantly. It's given bicarb. And here's the dashboard. So what do you think? Compressions per minute, 81.
CPR ratio is fairly good. Compression per ratio is good. Low good. And the compressions per minute, low good. So all within the green.
Yeah. In the hospital, this was case number 2. I think this came to Salmon Creek. And I think there was no cardiac activity on transthoracic ultrasounds, which we use in the emergency department now to examine these patients as quickly. Sometimes it's difficult because you don't have good echo windows and you want to get in and look real quick so you don't interrupt the flow of resuscitation. Interestingly enough, with ultrasound, you can actually see guide CPR. There are some resuscitation experts out there that are using this to, provide adequate assessment of the adequacy of compressions as far as the squeeze of the left or compression of the left ventricle, because it may not always be right under where the guidelines are for hand placement. Case number 3. Priority 2 for sick person, upgraded en route. CPR was in progress. This is another geriatric arrest. 85-year-old reports that he woke up and had some chest pain prior to collapsing. Daughter started CPR, had a stent placed a year and a half prior, and had a history of hyperlipidemia, hypertension, and prostate cancer. He was apneic, and he had good chest rise with bag valve mask. His initial rhythm was asystole, about 90-kilogram guy. Fire arrived to find him pulseless, and rhythm check was asystole, continued CPR, intubated with a good waveform. Right IO was started, given epi, and CPR continued. Rhythm check, he had a return of spontaneous circulation. He was moved to the ambulance and transported. Had vitals, so a good save here, 117/79, heart rate 100, end-tidal CO2 of 47. Those are all good indicators. No STEMI on the 12 lead. Second IV was placed, or attempted, but not successful. Patient was given some atropine for symptomatic bradycardia with no response. An attempt was done to pace, given some epi, and the rhythm recheck, he had recurrent PEA. CPR was continued and had return of spontaneous circulation, so in and out of arrest. And there's his EKG that shows some T-wave abnormalities, but no STEMI. And here's the dashboard again.
The problem with the dashboard is that it's the summation of
the whole thing.
So if you stop doing CPR, automatically your CPR per minute drops. So you really have to be able to go back and look at that thing and interpret what was on with the little red strips of the CPR strip. That's why you need to print that and look at it to solve the code.
So in the hospital, multiple rounds of ACLS treated for PEA. Again, in and out of perfusing rhythm and eventually pronounced after 30 minutes.
So this is a case that obviously starting out with asystole, low end of what happened, but a good attempt at resuscitation.
So case number 4, and this is the last one before we get out and enjoy that nice day. Spouse states woke and heard noise from where husband was asleep on the couch. Went to check on him, found him unresponsive with irregular breathing, and called 911. He was coached to check for a pulse, and she was trained in CPR.
I want to put this one on because this is a case where you arrive with a 2-person crew, and in this case, that's all they ended up with, because fire, this district, remote district out in wherever, never did respond. So it's a 2-person crew with the wife doing CPR.
Okay, so good quality CPR, but due to limited EMS personnel, continue to utilize spouse. Okay, so she's on the payroll. Patches placed and presenting cardiac rhythm VFib, defibrillated at 200 joules and continues CPR. Difficulty to blindly place an IV. IO placed appropriately, because anytime that IV is going to be difficult, you need to think about going to IO so you can get access. Epi was administered.
In this case, it sounds like the only light on in the room was the light coming from the life back, too, because for some reason there were no lights.
And he defibrillated again at 200 joules rather than 300. Intubated and tube position confirmed. End-tidal CO2, as you can see, is 54. ALPS kit was initiated. It's after the second? Mm-hmm. Okay, second shock. So 1A and 1B. Rhythm change to idioventricular without a pulse, so pulseless rhythm. And CPR.
Then to sinus rhythm.
Then to sinus rhythm. Okay, that's right. And then auto vent setup. 600 tidal volume and 12 breaths per minute. Due to the lack of additional personnel, patient was breathing over the vent. Versed was administered with no improvement. Due to the low blood pressure, sex administered with plan to continue Versed after improving blood pressure with IV fluids. I'm not sure that
this is kind of, I want to point this out.
Yeah.
Because here we had a patient who was fighting the vent, basically. Well, to me, even though you're low on personnel, I mean, my preference in that, if the patient's bucking the tube, you may not need that tube. You've got ROSC, may not need the tube. That's why I usually like to get to wait to intubate the patient. You know, this guy had a fairly rapid response. I'm not sure why he needed a tube right away. Any rate, then the medic made the choice to give, said wanted to make sure he kept that tube in there because they were shorthanded anyway. So he gave sucks. Sucks was not appropriate at that point. I would have gone right to VEC. He ultimately went to VEC anyway for the transport. So we've already discussed that with the medic.
And then transported code 3 to Southwest.
Okay, click it over. Okay.
VAC administered, these repeat first said, 12 lead EKG, sinus rhythm, and that was it. There's the 12 lead that really doesn't show a STEMI. 12 lead actually looks pretty darn good. In the hospital, admitted to ICU, cooled for 18 hours and passively rewarmed, extubated 2 days after admit. Not quite as sharp as he was when he initially had his arrest. So concerning for anoxic or hypoxic encephalopathy. Diagnosis was VFib arrest, cardiomyopathy, acute renal failure, history of alcoholism and tobacco abuse, and he was then he was transferred to Kaiser for his continued care.
Follow up on that. He has left. He did leave Kaiser after about a week, and actually is at home and is functional with probably a level 2. He's got a little bit of memory loss apparently, but he's doing normal activities, daily living, and he seems to be doing okay. I think he's had a AICD put in as well. But anyway, this is a good example of how you modify that pit crew to manage with the very small. They started doing CPR, and then because they kept waiting and waiting and waiting for District X to show up, they asked the wife, said, could you do compressions again? She said, sure. So she started doing compressions while they were busy doing the other thing. You use what you have. I mean, when they got there, the dispatcher was still on the phone with the wife counting. 1, 2, 3, 4, just counting for her. So she was doing pretty good CPR. So anyway, and this, has an ROSC and has a good outcome. So good management. This is, of course, out in rural area, so there was a little time to respond. So this was a really good case.
Yeah, good.
It's so great, great teamwork and great stuff. So, okay, any questions before we call it a day? All right. Next month will be skill stations at your stations, and what we'd like to encourage as much as possible is for the AMR crews to work with